patient, you have to ask for the attenders if he has any medication, any past illness, last meal, and what is the thing which has brought him, or the events which has brought him to the hospital, or the environment, what has happened. So look for the complete 8 to 2 examination here. Look for the inspection, palpation, signs of any fracture base, any crackling is present, pupil visual acuity, nose, especially rhinorrhea, and maxilla. Look for the fracture, that is like overriding mouth, and here look for the hemotympanum. Skull base, look for the hemotympanum, otorrhea, rhinorrhea, raccoon eyes, and battle sign. And neck, look for the inspection of the abrasion cartoon. Many a times, like we have seen patients where there will be just a plaster covering the neck of the patient. When you keep inspecting, always it is better to explore under some sedation or anesthesia. When you do it, like you can even see your major thing like your main vessels cut. All these things even can happen. So look for any mass. That mass can be an hematoma, a surgical emphysema, a trachea, carotid pulse, cervical spine fractures, and look for carotid rui, and which again indicates there is some injury to the major vessels. If there is any active bleeding and expanding hematoma, arterial bruit, airway compromise, usually it requires operative surgery. You have to pack it up immediately, shift the patient to OR, don't wait. Just ask for O negative blood and transfer the patient to a good center. Maybe not only a surgeon, you need to have a cardiovascular team. An unexplained or isolated paralysis of an apex extremity, always think in terms of the cervical nerve root injury and should be documented. More than treating this, the documentation part again, like one other person has to be there in your team to do it, because that is going to take you away from the medical legal things. The patient with facial-maxillary or head trauma should be present to have a cervical spine injury always. A fracture or a ligament injury and a cervical spine motion should be restricted. So the chest, always look for the inspection, palpation, percussion, auscultation, that is air entry and heart sounds. A contusion hematoma of the chest wall, alert the clinician for the possibility of occult injury. So this is the potential life-threatening injuries. Can be a pulmonary complications, your myocardial contusion, aortic tear, diaphragmatic tear, esophageal tear, tracheobronchial tear, early thoracotomy. If all these things is present, it is better to go for a thoracotomy rather than waiting and losing the patient. And hemorrhage, that is a massive hemorrhage. Massive hemorrhage, if it is going to be, if you put on ICD, if it is going to be more than 1500 ml, then you call that to be a massive hemothorax. Or if it is going to be 200 ml per hour for more than 4 hours, you call that to be massive hemothorax. So that is again an indication for opening up the